So I'd now like to introduce Carl Petrokofsky, I hope I pronounced that right, Carl, and Don Sinclair. We're going to do a bit of a double act on public health, and I'm going to let them do their own introductions, and we've got half an hour, and I'm going to do my best to get us back on time, but I'm not sure how I'll do. Thank you. Thanks, Carl.
Hi, many thanks. So I'm Carl Petrokofsky. I work for Public Health England, and I want to talk about promoting active travel. Now, of course, I have to start with two apologies. I arrived late. I've got to leave early. So that's an apology. But the biggest apology is almost everything I was going to say has already been said. So I was going to talk around some of the evidence on health transport, active travel and health, some of the work of my team, and just try to challenge and think about some new future. So we'll see where we go. The slides I'm going to rush over because you'll be able to see the slides for some of the detail. How many people here are from the transport world? Okay, I should say I could tell that because in my world in public health, I would say 60% of the audience, 70% of the audience here is male. In my world, it's always the other way around. So that's just one point. And while I'm talking around there, you can see what Public Health England does. But why are we in health here? Public Health England is an executive agency of the Department of Health. We're charged on behalf of the Secretary of State to help reduce health inequalities and improve health and well-being. And my team has been set up to look at the impacts of a built and natural environment on health, because we recognize the wider determinants of health, and it's not just around behavior, etc. Now, I don't know how many of you have seen this slide before, but this looks at and describes in a really neat way some of the key determinants of health. So your health is determined looking at the center there of who you are, your age, sex, your genetic background. That's going to have a huge impact on your future health. Coming out to the next ring, though, is your health is going to be determined around what you do. Do you smoke too much? Do you drink too much? What's your education level? Do you have good social networks? These are all impacting on your health. You have a good job. What's your education? And again, so we begin to see your behavior is impacting on that. The world that I'm generally dealing with my team, and I should say my team is me, myself, and one other person covering the country right now who's a town planner. So that's where our focus of our work is. But coming out to the blue, where you live is going to impact on your health. And this is what's your local environment like, what's the natural environment like. And increasingly, we know that your health is going to be impacted around where you don't live, and that refers to climate change, which is going to have a huge impact on health and well-being in the future. But I'm mostly going to deal in the blue ring today, but just reflecting on what we've said, it's the whole, I guess it's chicken and egg. Do you provide the infrastructure first and hope to get people cycling, or start changing the narrative and get behavior change? Now, one of the things, I think we've obviously got to do it together. And changing the narrative, I think, is crucially important. Now, what do I mean by this? How many people were watching television last night? Okay. In the past week? Most people? Right. How many of you saw an advertisement that said, get out and go take a nice walk? No. How many of you saw instead, get into your car, feel sexy, feel independent, and drive on roads that had no traffic? And also, if you watch sports like me, it said bet and drink beer at the same time as well. I'm not saying you should do all that together. But I think there is a narrative that's going on that it's impacting, and we have to change. If you want to get people cycling and walking, we need to address that. And we saw from our colleague from Transport for London all the various ways trying to influence behavior at a personal level, all the structural things that they're doing, but I think there's a wider narrative that we need to start addressing, and that takes government, and it's also really crucial around different economic interests, etc. Now, I'm going to jump back into a little bit around what I'm supposed to talk around healthy environments. We know that a healthy environment can help promote physical activity in everyday life, around particularly walking, cycling, can help people maintain healthy weights. As part of the wider picture, can help people can get access to healthy, affordable food. It promotes active travel, fewer injuries, etc. And I was really pleased with the London work around how the mayors tried to shape the transport strategy so it's not just around moving people from one to the other, and it relates to jobs, it relates to housing, and relates to health. Is anyone here from the West Midlands? No, good. I can say whatever I want. In the West Midlands, there is the equivalent to Transport for London strategy, which is just emerging, and the strategy Movement for Growth is looking to see an emphasis in travel, moving more towards large European city regions where car use is typically 35 to 40% of all journeys, compared to 63% in the West Midlands. Now, of course, the West Midlands, the heart of UK motor manufacturing, a real challenge. But what are the implications of not achieving what they want to do over the coming years? Now, we've seen some of the modeling tool around the heat tool, and I'm going to come back to that in a second. But just to put a little bit of context around this, we know that inactivity is killing us, and we know that adults are 20% less active than they were in the 1960s, and if current trends continue, by 2030, we'll be 35% less active than previously. Why is this important? We know that physical inactivity is responsible for at least 1 in 6 deaths in the UK. Something like 37,000 deaths per year could be avoided just through physical activity, and we've seen some of that, how that's been modeled. And we know it's not just deaths. We know that it's a risk factor, physical inactivity, in about 40% of long-term conditions. And if you haven't seen this graph, this begins to demonstrate some of the evidence base of where being physically active contributes to risk reduction on a whole range of diseases and conditions: diabetes, cancer, depression, hip fracture, Alzheimer's, etc. And the chief medical officer a few years ago noted this and noted the potential benefits of physical activity to health are huge, and if a medication existed which had a similar effect, it would be regarded as a wonder drug or a miracle cure. So that's where we're coming from a public health perspective. We've talked about, colleagues have talked about active travel, why it's so important, because we know building walking and cycling into daily routines is a key way of promoting physical activity. And indeed, people who cycle for travel purposes are 4 times as likely to meet physical activity guidelines than those who don't. Now, we know that the growth in road transport has been a major factor in helping reduce levels of physical activity and some of the increase in obesity. And if you don't know, we have an obesity epidemic in this country. We are the most obese country in Europe. Now, what are some of the areas? Well, we've seen in London, short car trips under 5 miles are a prime area for switching to active travel and public transport. Last week, I live in Oxford, and I enjoyed seeing some of the pictures in the previous presentation from Oxford. When I cycled down to the train station, I zoomed by. I got there in I think it was about 12 minutes, and I wasn't racing, being a boy racer or anything. I'm past that. But today, when I was coming here, it took me twice as long. Why? Because last week was half term, and simply the roads where I live empties out at half term. And this is a prime area. Why are we driving kids to school? Why? All sorts of reasons, because we know it's dangerous for them to walk. We know it's convenient often for parents who think they're doing the kids a good job to drop the kids off at school, etc., etc. The one thing we do know is that a health-promoting transport system is pro-business. It supports economic prosperity. We were hearing some of the impacts in London earlier on. And basically, the general thing we see is what's good for health is good for the environment and is good for the economy. Now, I said I'd refer back to, and I think it refers also to one of the questions that were done before. There is another tool around. It's a Sport England Moves tool. And in the West Midlands, they just modeled something to see if cycling was currently 5% of trips, what would happen to some disease rates over the next 10 years. And so there'd be a reduction of about 10,000 hip fractures. Now, I did some back-of-the-envelope, literally, calculations around that, and I reckon that would save about £25 million just on hip fractures alone. You could easily begin to put more accurate figures in this and start coming up with some real figures. So this is a win for the health service, it's a win for individuals, and I think it's a win for our towns and cities. Again, if we promote more walking and cycling, there are a whole range of other benefits that start spinning out around less car travel, pollution, less congestion, safer and more welcoming streets, increased social interaction, and again, supporting local business. Again, this is stolen from a colleague from Transport for London. We need to acknowledge motorized road transport has provided many benefits to society over the past years, but increasingly the costs of road transport are beginning, to me, to outweigh the benefits. And looking at physical inactivity, air pollution, you start pulling these together, that's some of the health impacts of what we're beginning to see by a reliance on road transport. Again, taking a look at it another way, you begin to have a jigsaw of health issues that are there. Again, what are some of the economics around this? We know physical inactivity is costing over £7 billion a year to business and wider society. That's not just health. Firms are losing workforce because they're off sick, etc. Education is suffering, etc. Air pollution. I think air pollution over the past year is the new kid on the block in terms of a health hazard, and is a real way for public health people to start having discussions locally. If you start saying, oh, your kid's physically inactive or they're overweight, parents start worrying about that. If you say that your kid is starting to get asthma because of air pollution, many of you are coming down with lung cancer because of air pollution. To me, this is a really powerful way to start having those discussions. Now, let's start reimagining a world where we're not surrendering everything to the car. I think as we've seen up in Walthamstow, these are the sorts of debates you have to have with local residents, with businesses. In Leeds, they turfed over a street a few years ago for a weekend. So the first thing we saw is kids got out on the street. Second thing we saw is the whole neighborhood got out on the street, started meeting their neighbors. Why is this important? We know that social isolation is a huge risk factor in itself, and community cohesion is really important for health and well-being. I don't know how many of you have seen this. This is based on two studies that were done, one in San Francisco and then repeated in Bristol a few years ago. This is an area with heavy traffic. That's a street, and this is the lines are showing where people know their neighbors and friends and acquaintances. And in this heavy street, you can see virtually nothing going across the street compared to an area of light traffic where there's so much more social interaction going on. This is what community severance is all about, and this is the wider impacts of a reliance on road transport and how we're dominating our life and the life of our cities with road transport. I don't know how many of you have ever been in Blackpool on the beach there and tried to walk into the center of town. I know when I was there, it took me about 5 minutes to cross the street into the center of town, and where the nearest pedestrian crossing was about 400 yards down the road. I didn't want to walk that far, but this is putting a priority over drivers, over pedestrians. When I asked some of the transport planners up in Blackpool, they said, that's perfect. That's what they had designed, because it was designed to get the traffic through and around the other bits of the town. But there are consequences. We've done some work looking at what a healthy community might look like. What are the design features around that, around compact, mixed use, highly walkable, free from pollution. And again, this is another way of showing what a healthy neighborhood might look like. You've got access to services, it's warm, comforty. There's lots of green areas you get around. And unfortunately, that's what we find all too often, is that to get around, you've got that traffic to contend with. And then, now outside of London, for those of you who are living out in some of the Shire counties, we have some really nice market towns. The problem is, how do you get around from one to the other? That's a bus, and if you notice on the front of the bus, that is a bicycle. So you could get on and say, I make it up in Witney and go to Chipping Norton and then start cycling around, because it is pretty hilly and a bit difficult to cycle to. But because of some of the rules around transport, we are not allowed to put bikes on the front of buses. And I think that's the sort of thing we have to start encouraging, thinking about, and starting getting people to think differently. When I've been in discussion with a lot of colleagues in Department for Transport, a lot of the future dialogue, they're trying to see what is the future of transport and looking at digital implications and autonomous vehicles. Now, of course, autonomous vehicles are fantastic. I would argue it's not for a guy that looks like that. He should be out on his bike walking around. That should be for my 96-year-old mother who's at risk of having to move from her home into a residential care home because she's just lost her driving license last week. Yes, we won't go there. But that could have a real liberating effect. But a reliance on autonomous vehicles is not going to solve our physical inactivity crisis. Just to wind up, our program, we've produced a range of briefings for public health practitioners and for planners and transport planners. A few in particular around working together to promote active travel has been looking at some of this and trying to help establish a dialogue between our public health practitioners and transport planners. Somebody said before they hadn't seen what was the big difference. They'd done a report 15 years ago, what's happened? To me, the significant thing that happened about 4 years ago is public health went from the NHS into local authorities, are now sitting in the same buildings with transport planners and often with spatial planners, and can now start having these dialogues like we're having today on a much wider impact. So I'm quite hopeful about the future. We've recently done an evidence base, because we do have to look at what is the evidence around health and well-being and active travel. Transport was one of the key elements that we covered, and we produced an infographic looking at the health impacts and came up with some planning principles around that. I'm not going to go through the details. Just to say some concluding thoughts. We think that considerate design of the wider environment is fundamental to keeping people healthy and promoting health. We think you can begin to use public concern around health issues such as air pollution to start discussions around how the wider built and natural environment can protect, promote, improve health and well-being and also to prevent ill health. We think you can use this to start changing some of the narrative, and I think there's a real opportunity for planners and transport planners working together with health colleagues who have a key role in creating places that support healthy lifestyles. And we're beginning to see that around the country. And I think at the policy level, we have an opportunity to use changes in the built environment to make progress towards healthier, more sustainable communities. And as I said, generally what we see is what's good for health is good for the environment and good for the economy. That's a so-called cycle path in Oxford that I was cycling the other day. I had to go out and avoid the car, and I nearly got knocked off my bike because of that. Infrastructure is crucially important, well-designed infrastructure. I'll send, when you get this, you can see there's some forums that we've got and a current awareness bulletin that we send, and I'll shut up then. Thank you very much.
Thanks, Carl, for warming everybody up for my slightly less exciting bit, I'm sure. I'm Don Sinclair. I lead the Local Knowledge and Intelligence Service part of Public Health England for the South East. There are 8 other equivalents of myself scattered throughout the country. Sounds like a grand title. I'm afraid there's only 8 people in my team. I didn't realise it was so much bigger than Carl's. I shall be smug about this later. But I'd like to tell you a little bit about some of the information that we produce to help people make decisions locally. I used to be Director of Public Health in Slough, and in those days public health was seen as an NHS thing, but with the Health and Social Care Act and the creation of Public Health England, and the recognition that most of the factors that actually affect the health of the population are really very little to do with the health service. They exist out in the real world, and people in local authorities control, influence, are able to improve many of those important factors. So this was a good thing. Just as the local authorities have been acknowledged as the leaders for health improvement, so Public Health England has been set up to support. And I must emphasise it is to support. We are not in a position to tell people what to do. We may be in a position to help those conversations happen. In summary, very quickly, what my bit of Public Health England does in the knowledge and intelligence function, we try to support health improvement with information. And we're very much answering the questions that go along these lines. What's bad in my patch? How does it compare to somewhere else that I really wouldn't want to look bad compared to? Is it getting worse over time? Is it something we can actually do something about? How could I tell if we do a good job? And of all the 100 things that we've been told we have to do, which 2 that we can afford to do shall we do now? So in my little patch, we've got a local analysis service. We do some analyses on behalf of our local authority colleagues or our local NHS colleagues, but actually quite often we're helping them to do the analyses that they need to do, because there are very few of us. To be fair, there aren't as many of them as there were. Knowledge mobilisation is very much about getting information that we have in the centre, perhaps nicked from Carl, and getting it out to the people who need it and helping them to work out what it means for them locally, if they don't have the resources to do that themselves. But also, and crucially, it's about listening to what they say, so that what we either do in the South East or what is done centrally in Public Health England is informed by the needs and the decisions that are being made and tackled locally. And the final bit, and actually what is proving to be one of the biggest aspects of work for my little team, is local training and workforce development. As the workforce shrinks, and we all know why that's happening, we have to try very hard to help people have the skills that they need out in local authorities and the local NHS to do the jobs they have to do. We can't do all the jobs that they have to do, but if we can give them some of the skills and help those be spread out throughout the councils, maybe we can together tackle what needs to be done. Now, for today, and the reason that I'm here, I'm going to tell you some stuff which I hope will be useful, but more importantly from my personal perspective, I want to discuss some indicators that we've been using based on to look at road traffic injuries, and I want your advice because, as Carl's just had you demonstrate, you're from a transport background and I'm not, so I'd like to nick your expertise while I'm here, if you don't mind. Now, one of the things that Public Health England does is it produces a lot of standardised information products based on data that we get quite often from NHS Digital, Office of National Statistics or other sources, for example, Stats 19 data from Department of Transport. We analyse this and we present it at the levels where decisions are often made. And we try to allow people to choose comparisons. So this, what I'm showing you here, is a publicly available suite of tools. We commonly call these the fingertips tools because the platform that displays it is called Fingertips. Each of these different headings is a separate tool. And what happens if you go onto this and use one of these is it will take information from a database at the back and it will show it in a variety of ways to hopefully answer those questions. What's bad? What's good here? Is it getting better, worse? Are we really as bad as Salford? Health profiles is one example that I'll talk about for a moment. It's one of my favourites because I ran the Health Profiles project for a while. And the Public Health Outcomes Framework, which I'll also mention because it is incredibly important. It was set up as a way of keeping track of what's going on in terms of the health of the population in a systematic way across England. Here are some of the health profiles. A health profile, when I'm talking about a health profile, it's a summary of information which in its PDF form spans 4 pages. Let's have the 4th page up there. Don't know why that didn't come up there. Here it is. And it's used to start a conversation at a local authority level, perhaps in the Health and Wellbeing Board, so that people can say, okay, here's a summary, text summary on the front, generated by computer based on the data, saying that for Barkingham-Dagenham, here are some things you might want to think about. And then a little bit more data through the rest of the profile, with the back page being a spine chart, 31 or 32 indicators compared to England as the benchmark. This would be used with councillors, council members at a Health and Wellbeing Board to start a discussion. It will not tell you what to do. It will only start that conversation, because what this doesn't know is what's actually going on in that local authority and what the political priorities and the people's priorities are. So it's start the conversation. It's also available via the Fingertips platform, where you can get other benchmarks. A lot of people will say, why on earth would I want to compare myself with the England average? That's hardly a target to aspire to, is it? And Carl's just given some examples. If you compare yourself to a regional benchmark, or to a benchmark perhaps based on places with comparable deprivation, you may then have a better idea of where you're aiming. Okay, if you're Wokingham, there's really nowhere richer, but you get my point. Okay, here are some charts, and these are getting a little bit more topic focused here. Do you see? From the Fingertips platform, looking at indicators in the public health outcomes framework. And here I've introduced, an indicator of children killed and seriously injured in road traffic accidents. Now, there's no doubting that that's a very important public health topic. But what are you going to do today when you're planning in your local authority? How are you going to decide whether this is a particular priority for you? If you don't already know, and of course, if you've got your local transport planner sitting next to you, he will tell you. But you might want to compare this over time or with other local authorities. The way that this particular display has been organised is to look across the southeast region for this particular indicator and to compare it with, in this case, a national benchmark. And you can see that that's the case when you look at the map. It looks a bit like a diseased liver to me, to be perfectly honest. But the point of this display is that we have a benchmark and a statistical test for each local authority. And that's what we're representing with the colours here. We try to use different colour densities, by the way, just in case anyone is colourblind. So red would be statistically significantly worse than the benchmark, which in this case is England. Green, statistically significantly better. And you can see that we've got confidence intervals where we look at the individual local authorities on the left to actually allow some degree of comparison between the local authorities. Immediately, Isle of Wight and Southampton are standing out because they're red. And you can see that actually there's not that big a difference between them and many of the yellow local authorities, but there's certainly a big difference between Slough, yes, and West Berkshire, which are shown in green. There's a trend in time for Oxfordshire. Okay, we don't just count bad things. Obviously, child accidents are a very bad thing. We also try and count good things insofar as we can. And here's a relatively new product that's available from Public Health England. These are all freely available. I'll tell you how to get them later if you want. This is the health assets profile. And just as you're thinking to yourself, how on earth are we ever going to get them out of their cars? How are we going to get them out of their houses? How are we going to get them to walk somewhere? It might be quite useful to have some sort of comparative assessment of whether you have access to woodlands, whether you have access to places that feel safe. Now, when I was Director of Public Health in Slough, we set up, as many local authorities did, the Walk in the Way to Health scheme. And the idea was that people would get together and go on healthy walks, and it would be nice, and they'd talk to each other, and that would be fine. But everybody knew that if you go walking in a park in Slough, you get mugged. Oh dear. There was a certain amount of concern about this scheme. The police said they would very happily reroute their cycle patrols, because the police loved cycling, along the lines of the walking route, and at the time, so people could see police officers and feel safer. So they started to do this. And at the start of the scheme, people huddled, and they looked around them, and they looked for the police officer. After a very short while, when they realised that actually they didn't get mugged and the parks were really pleasant, they spread out, they talked in a more relaxed fashion. It worked very well for the duration of the scheme. And the police still kept cycling there because they liked it. Okay, I want to talk about a specific indicator. I've given you some examples of indicators. you haven't had the time to investigate them. You can look at all these tools online. There's all sorts of wonderful details about the metadata. But we were interested to look at how the numbers of people who are killed and seriously injured on the roads varies between places. This is an important public health outcomes framework indicator because it is such an important thing. Now, we can count the numbers, but there's all sorts of issues around counting the numbers. What does it mean as a proportion of the population or what? And how do you compare and how do you work out the rates and how do you work out the confidence intervals and do the statistical tests and all sorts of things? So we had to have a numerator, the number of people of all ages reported killed or seriously injured on the roads in a local authority, and we needed a denominator. And so we used the census-based resident population. We describe it as our least worst methodology. We couldn't think of a better one, but we didn't think it was very good. However, it gets people talking about injuries, and that is really important in its own right. And there's a debate about the suitability of the denominator, because if you've got a very small resident population, guess what? You get a very big fraction. Now, here is our KSI indicator from the Public Health Outcomes Framework. And I've ranked it for the South East local authorities, because the South East is my patch. As you can see the value for England, 38.5 people killed or seriously injured on the roads per 100,000 resident population per year, and the indicator periods between 2013 and 2015. South East, slightly worse than the England average. Now, isn't that interesting? Rich and healthy place like the South East, worse than the England average. And in the very worst place in the South East is East Sussex. So if I were a DPH for East Sussex, which I wasn't, I could look at that and feel suitably horrified. I could look at the map and compare and see, where else on the map might I compare myself? East Sussex. Okay, pick an appropriate comparator and see if I'm better or worse than them. I could use this tool to test, and I can look at the trends over time, which I have to say don't look great. Okay, well, that's the indicator. But what happens, and here are some other similar indicators. Note the top one's killed and seriously injured. We've just looked at that, and this is for East Sussex. I might also want to see how children are affected. You can see the children's value below. And also alcohol-related road traffic accidents, just to see how big an issue that is in East Sussex. Okay. But what about this business about the resident population as a denominator? Can we think of something better? Well, ONS has released in 2015 the road lengths report. So we thought, let's see what it looks like if you adjust this not by the resident population, but by the amount of road you've actually got. We haven't got pretty charts. This is a work in progress that one of my team is doing, and this output's come from R. I suspect you probably knew that, but it's come from R. And if you look at this, the top 10 rankings in England for numbers killed or seriously injured per 1,000 kilometres length of road in upper tier local authorities. Right at the top is, of course, City of London. I think it's probably getting better now because you're stopping transport, a lot of driving in the City of London. But then, of course, the City of London's got a resident population between 2,000 and 3,000, hasn't it? We'll come back to that in a moment. It's got a lot of roads too. And the second one is Westminster. Well, they're not in my patch. They're someone else's worry. In my patch, the top two are Brighton and Hove and Portsmouth. Okay, let's see how that compares to the previous indicator that I was telling you based on the resident population. City of London is still top, but there's between 2,000 and 3,000 people who live there, and a vast number, I've forgotten the number, but it's huge, of people who work there. And I don't know the balance between people who come in to work and get flattened as opposed to people who live there and have something horrible happen to them. Westminster is still second. Okay, so that's fairly comparable. But what about in my patch? Now, Brighton and Hove and Portsmouth were the top two if you worked out the numbers killed or seriously injured per 1,000 kilometres of road. They're still high, and they're statistically significantly higher than England, but they're not the top anymore. They are lower down than East Sussex and a number of other places. That's interesting. If we look at the other end of the table, Devon is in the bottom 10. Where does Devon count? Well, Devon is actually one of the worst places in the southwest and is statistically significantly worse than England. So this is making me think my two indicators are telling me different things. And if I do a correlation between the pair of them, there really isn't any correlation at all, is there? They're telling us different things. Okay, let's have a quick look at the new denominator, the 1,000 kilometres of road per local authority. This is a heat map, meaning a different sort of heat now, looking at local authorities ranked into deciles and with a heat scale. And you can see the patches where there is a lot of road. So, is my new indicator really usefully telling me how much less safe local roads are? Or is it an indicator that's really just showing how much road busyness there is? And to be perfectly frank, if you're looking at ways of making your roads safer, giving cyclists and pedestrians more confidence, does it actually matter if there's a distinction between these two? Okay. Deprivation, inequalities, absolutely critically important. Penultimate slide, you'll be pleased to know. People from poorer places have more accidents and have higher rates of fatalities, irrespective of whether it's a leafy green rural place or an urban place. There are all sorts of issues. We've looked at types of road, we've looked at speed limits on road, all sorts of things. And the greatest number of casualties, of course, occur where the greatest number of people are in contact with traffic, where typically we've got your 30-mile-an-hour limits. So there's a big inequalities issue here as well. And now my questions to you. Can you give me some sort of clue as to what would be most useful? What of our indicators could help you in trying to make decisions about improving road safety, improving the feeling of safetiness on roads, that people will actually go and use them? And what might be your priorities? And indeed, any advice about the methodologies of the indicators? Thank you.
Thank you very much. Let's go for it. Any questions? For Carl or Dan? This one here. Throwing caution to the wind now and just forgetting the timing. Have you noticed that?
Sorry about that.
No, it's
his
fine.
fault.
It's fine. It's fine. It means I'll talk less later.
Hi, I'm Jeff Gardner, formerly with TRL, now a freelance. Work I've done on transport and health. One of the questions that come up is, should the new directors of public health within the local authorities be statutory consultees on planning applications?
Yes, that's very easy. They should be.
It's one of the things that concerned me when Marcus showed that slide of the turning radii. At the moment, the county highways will say, no, we must have big, wide turning radii, and they get listened to, and health doesn't get us a look in.
And my understanding is that they would be already, because directors of public health are in the local authority. And then it's up to whoever's receiving this in the local authority to be sharing that with their colleagues, say if it comes into the chief executive's office. So they should, as a response from the local authority, they are part of the statutory process. And there's been a debate whether we need to change that and highlight directors of public health. But right now, they're in there, and we're quite clear about that.
They comment on things like how many surgery places per 1,000 population and stuff, don't they? But they don't necessarily look at road layouts and whether anything's within a 1 kilometre walking distance, for example.
Unless it's changed very recently, there were when there was issues about alcohol control zones and all sorts of other things, that health wasn't formally a statutory consultee unless a particular process had been invoked. If it were up to me, I would make them specifically statutory consultees.
What I'm going to do,
it's not up to me.
What I'm going to do is I'm going to just thank you so much.